I'd like to thank you for taking the time to join me on this video. Purpose of today's video is to share with you and to talk with you about some of the physical examination maneuvers that we use for the determination of carpal tunnel syndrome. Now, I'm certain that you've evaluated patients or examinees prior with carpal tunnel syndrome, and so you're probably going to be familiar with several of the maneuvers that we go over here today. But I believe that I'll probably have a couple of new maneuvers for you that you've either not seen before, or perhaps you've seen them and you just simply haven't implemented them into your practice. And I'm going to share with you the utility of these new maneuvers, and they may be maneuvers that you may want to integrate into your routine physical examination procedures. Now, the first maneuver that I want to go over with you is known as the Phelan's maneuver. And the Phelan's maneuver is described in the AMA guides, and I'm certain that you're all familiar with the Phelan's maneuver and its brother, the reverse Phelan's maneuver, but sometimes we get the two confused. So remember that the Phelan's maneuver involves hyperflexion of the wrist. This is flexion of the wrist. So the Phelan's maneuver involves hyperflexion of the wrist, and the reverse Phelan's maneuver involves hyperextension of the wrist. Okay, so to perform the Phelan's maneuver, I've seen it described in the literature as being performed many different ways, many different descriptions in the literature as to how this maneuver is performed. Consistent among all the descriptions in the literature are that the wrist is placed in hyperflexion. For example, I've seen one description in the literature that requires the subject to simply place their forearms on a table and allowing the wrist to drape over the end of the table in hyperflexion. That could work. Probably the simplest way to do this in a clinical setting is to simply ask your examinee to place the dorsa of the wrists in contact, and then simply elevate the elbows, bringing the wrists into maximum hyperflexion. And you'll notice that my wrists are in maximum hyperflexion, and if you'll take my word for it, they are. There's really not much flexion left in the wrist. So this maneuver actually does recreate maximum flexion of the wrist. So to begin with the dorsa of the wrist down here, and then simply raise the elbows up to bring the wrists into maximum hyperflexion. Now, common errors in the performance of this maneuver are many, and it's up to you to make the necessary corrections so that you get the true performance of the maneuver. But typically what you'll see is the examinee, in one way, shape, or form, fails to fully approximate the dorsa of the wrists together. They'll keep the dorsa of the wrists apart. And so you can encourage the examinee to bring their wrists together by applying a little pressure to the elbows to encourage them to maximally hyperflex the wrists. And indeed, you may want to add a little bit of pressure to the elbows to make sure that in addition to maximum hyperflexion, they're getting a little bit of overpressure and a little bit of compression there to fully tease out any median nerve lesion that may be in there. And so once they're in this position, they're going to want to hold this position for 30 to 60 seconds. And a positive finding on this Phelan's maneuver would be a reproduction of carpal tunnel syndrome symptoms, which would involve numbness and or tingling in the thumb, the index, the middle, and the radial half of the ring finger. Now, you don't tell your examinee what symptoms they're supposed to experience with this maneuver, if any. You simply perform the maneuver and ask them to report to you what this maneuver does to them. They should be accurate in describing reproduction of symptoms in the form of numbness or tingling in any of these fingers. Thumb, index, middle, and or the radial half of the ring finger. So let's think about this. With this maneuver, the reproduction of symptoms is a subjective report by the examinee, correct? Well, what kind of positive objective finding do you think could accompany and could substantiate or could indicate validity to the examinee's subjective report of symptoms? In other words, there should be some sort of objective finding to accompany the subjective report, correct? That would indicate a valid reproduction of symptoms, correct? Well, probably the most common objective finding that will accompany a bona fide reproduction of symptoms is what's known as the shake sign or the flick sign. And those that have had carpal tunnel syndrome before will tell you, and if you've ever seen somebody with bona fide carpal tunnel syndrome, you'll notice that they frequently shake or flick their hand. And the purpose of shaking and flicking in the hand is to attempt to reperfuse the median nerve, which is complaining of ischemia at the time that the symptoms are manifesting themselves. So with a reproduction of symptoms, you would expect to see perhaps a shake sign or a flick sign as a positive objective finding that would then substantiate the positivity of this maneuver. Okay? So that is the Phalen's maneuver. And then the reverse Phalen's maneuver is just the opposite. And what these maneuvers have in common, whether we're talking about maximum hyperflexion or maximum hyperextension, is that both of these positions narrow and compress the contents within the carpal tunnel. So to perform the reverse Phalen's maneuver, probably the easiest way to do that is to simply ask the examinee to place their palms and fingertips together and then to raise the elbows, bringing the wrist, therefore, into maximum now hyperextension. Now, common error, again, in the performance of this maneuver involves the examinee not approximating the palms, not bringing the wrist into maximum hyperextension. And the way that you can ensure that you're getting maximum hyperextension is to make sure that the examinee elevates the elbows. Elevates the elbows. See, as I elevate my elbow, my wrist goes further and further into extension. Now notice here, as my elbows drop, the wrist extension angle diminishes. So you want to bring the elbows up maximally. And you can encourage proper performance by applying a little pressure inwards to the elbows, thereby giving a little bit of over compression to the maneuver. And you would hold this maneuver for 30 to 60 seconds, at which time you would expect to see some reproduction of the carpal tunnel syndrome symptoms, which would include numbness and tingling, and hopefully that subjective report would be accompanied by a true objective finding, such as the shake or the flick sign. Okay, the next maneuver I want to go over with you is known as the median nerve percussion maneuver, or the median nerve compression maneuver, also known as the Tunnel sign. You'll see it described in the literature many different ways. Typically it's described now as the median nerve percussion maneuver, as we're getting away from these eponyms, medical eponyms. So whether it's the Tunnel sign or the median nerve percussion maneuver, the purpose of this maneuver is to sharply irritate, sharply aggravate, sharply compress the median nerve an inflamed and ischemic median nerve as it passes underneath the transverse carpal ligament and the flexor retinaculum. Now, you can perform Tinel's maneuver in a variety of different ways. You can use a reflex hammer, or you can simply use your own 2 fingers to tap over that nerve. And I've seen this maneuver described in the literature several different ways. One reference that I read recently stated that for this test to be considered positive, it must reproduce the examinee's symptoms within 2 taps. And then I've seen references, for example, here in the ACOM guidelines, which describes testing for Tinel's sign, states that up to 6 taps may be required to produce a positive finding. So somewhere between 2 and 6 taps may reproduce the examinee's carpal tunnel symptoms in the case of true pathology of the median nerve. In my opinion, I think 2 taps is probably not sufficient, because it could take simply 2 taps to get the right location, to get the right amount of percussion pressure, etc. So I would consider the test to be positive somewhere within 2 to 6 taps. So to perform this maneuver, you simply take your percussion hammer or your 2 fingers and tap over the median nerve as it passes underneath the transverse carpal ligament and then the flexor retinaculum. And you can identify and locate that area by simply tracing up the 3rd metacarpal up into the palm, and that gives you a pretty good localization of where the median nerve is as it passes through the carpal tunnel. Simply trace up the 3rd metacarpal bone, and that would be where the median nerve would lie. So you simply tap over that median nerve 2 to 6 times and determine if that reproduces the examinee's symptoms. Now, I can do this here on myself, and there is no indication, no reproduction of any symptoms into my fingers or palm, because I don't have an active median nerve lesion. But in a person with an active median nerve lesion, this test will sufficiently provoke the median nerve and reproduce the symptoms. And you may wonder about the sensitivity and specificity of these tests, because many times some of these physical examination maneuvers that we do have been questioned as to their actual accuracy in being able to identify the condition in question. And so I did some research on these maneuvers, and I found that this very issue was investigated in 1986. And in a study published in the Journal of Bone and Joint Surgery, they evaluated these tests for the determination of carpal tunnel syndrome. And I've included this for you in your reference materials for this program. And very quickly, I just want to go over the abstract of this study. And they stated that in order to evaluate the usefulness of provocative tests, and that's what these are provocative tests. Tests that have as their purpose either compression, stretching, or otherwise irritating the median nerve. These are provocative tests designed to provoke an already inflamed or already pathologic median nerve. So in order to evaluate the usefulness of provocative tests, such as the wrist flexion test, which we call the Phelan's test, the nerve percussion test, which we call the Tinel's test, and another test known as the tourniquet test, which we won't demonstrate here. But that's a known test for the evaluation of carpal tunnel syndrome. The results of provocative testing were evaluated in a group of patients, meaning 67 hands. They took 67 hands each of which had been electrodiagnostically tested and proven to have median nerve compression. And they compared these 67 hands with a group of 50 control subjects who did not have electrodiagnostic findings for median nerve compression. Okay, so they had 57 hands who had a history and electrodiagnostic proof of median nerve dysfunction, and compared those with 50 control subjects who had no symptoms and no electrodiagnostic findings for median nerve dysfunction. And they put these two groups through wrist flexion testing, nerve percussion testing, and tourniquet testing to determine the accuracy of these maneuvers in predicting the condition of carpal tunnel syndrome. And they stated that the sensitivity and specificity of each test were calculated. And recall that the sensitivity is the ability of the test to identify true positives, to accurately identify the presence of the condition when this test finding is positive. Specificity, on the other hand, is the ability to identify the true negatives. Okay? These are opposite. So a specific test would be negative in every person without the condition. Okay? So we have sensitivity and specificity. And so they evaluated these tests for how able they are to identify the true positives and how able they are to identify the true negatives. The wrist flexion test was found to be the most sensitive, the most capable of identifying those with the condition. The most sensitive of these three maneuvers. While the nerve percussion test, although it was the least sensitive, was the most specific, meaning that people without median nerve pathology do not respond to this test. They don't complain that this reproduces their maneuver. In other words, the Tinel's tapping will not reproduce symptoms in a person without median nerve pathology. Very specific. Interesting. The tourniquet test was quite insensitive and not very specific, and should not be used as a routine screening test in the diagnosis of carpal tunnel syndrome. So these two tests, the Phelan's test and the Tinel's test, are very accurate in identifying carpal tunnel syndrome. And when you couple that, the ability of these tests to reproduce the symptoms, when you couple that with the presence of a true objective finding such as the flick test or the hand shake sign or the flick sign, pretty solid and valid indicator of bona fide carpal tunnel syndrome. So in addition to those, we also have the reverse Phelan's. And I want to go over some other tests with you now that you may or may not have heard of, but that you can incorporate into your normal physical exam procedure as the needs may require. So the first one I want to go over with you is called the Durkheim's compression test. And this is described in the AMA guides. It's not described, this is described in the ACOM guides. It is not described in the AMA guides. But the Durkheim's compression test is a lot like the Tinel's test, whereas the Tinel's test, however, involves an instantaneous compression to the median nerve. The Durkheim's compression test involves a sustained compression to the median nerve. So in order to perform the Durkheim's compression test, you simply take your thumbs and apply direct and sustained pressure over the median nerve at the flexor retinaculum. So I can't use both thumbs here to demonstrate to you, but you would take your two thumbs and put them side by side directly over the median nerve and apply sustained and deep pressure, again for 30 to 60 seconds, looking for the reproduction of pain, numbness and tingling symptoms in the distribution of the median nerve. The Dirkhan's compression maneuver. The next maneuver I want to share with you is one that you may not have heard of. And it's known as the three-jaw chuck maneuver. And this is an excellent maneuver. And I really like this maneuver. The purpose of this maneuver is to identify those cases of carpal tunnel syndrome that may be due to tendinitis. And you've probably had clinical patients and examinees tell you that they've been diagnosed with tendinitis of the wrist, and it's the tendinitis that's responsible for their carpal tunnel syndromes, carpal tunnel syndrome symptoms, carpal tunnel symptoms. And so let's go into that. Well, the three-jaw chuck maneuver is performed by taking the distal phalanges of the thumb, the index, and the middle fingers and bringing them together. These are the three jaws of the chuck. And you take those three jaws and you bring them together and you ask the examinee to apply pressure to the pulps of the distal phalanges. And I don't know if you can see my muscles tensing, but I'm squeezing quite hard here. And that's what you want your examinee to do. Now, the philosophy of this maneuver is that this tensing of these muscles brings to attention and tension the tendons that pass through the carpal tunnel. Now recall that there are 9 tendons that pass through the carpal tunnel. You have 4 tendons of the flexor digitorum superficialis, 4 tendons of the flexor digitorum profundus, and 1 tendon of the flexor pollicis longus. All of these pass through the carpal tunnel along with the median nerve. Well, each of these 9 tendons are wrapped in a synovial sheath. They're lined by a synovial membrane. And with inflammation or congestion due to repetitive use or even a single trauma, these tendon sheaths can become inflamed, and we call that tendinitis or tenosynovitis. Well, because the carpal tunnel is a fixed fibroosseous tunnel with no room for expansion, as these synovial membranes expand, something's got to give, and it's the median nerve that then gets compressed and collapsed. And this maneuver is useful for identifying tenosynovitis as a potential cause. So to perform the maneuver, you take the 3 jaws of the chuck, bring them together with pressure, and you encourage pressure with your examinee by taking your own fingers, overlying their fingers, and squeezing hard to demonstrate to them that you want the firm application of pressure here. Once the firm application of pressure is established, the examinee then maximally flexes their wrist, meanwhile sustaining the pressure on the fingertips. And you would encourage them to do that by squeezing their fingertips here. You might even demonstrate like this with this body language to show them that you want firm pressure. And you'll notice that this is the same as the Phalen's maneuver. So we have the maximum flexion just like the Phalen's maneuver, with the addition of the tensioning and tensing of these tendons as they pass through the carpal tunnel. And this may reproduce the symptoms in the distribution of the median nerve, which would be an indication of a bona fide lesion of the median nerve, especially if it's accompanied by an objective finding. Or perhaps if it's accompanied by a reflex inhibition, where the examinee says, no, I can't do that. In other words, reflex inhibition, withdrawal reflex from something that's sharply painful. Okay? Okay, so that's the three-jaw chuck maneuver. And then the final maneuver I want to share with you is known as the square wrist sign. And I really like this measurement as well. I like this test. It's not described in the AMA guides, but it is described in the ACOM guidelines. And I'll read from the ACOM guidelines for you. This is on page 261 of the ACOM guidelines. It states here that when checking for the square wrist sign, and let me just give you a little philosophy about the square wrist. If you look at your wrist, you'll notice that your wrist is wider than it is thick. That makes sense, right? It's wider than it is thick, and those distances can be measured. The width can be measured and the thickness can be measured. Well, in the presence of congestion, tenosynovitis, trapped edema, scarification, the thickness of the wrist can increase. And the wrist would start to look, instead of rectangular, it would start to look square, as thick as it is wide, the square wrist sign. So according to the ACOM guidelines, they say that the square wrist sign is positive if the ratio of the thickness of the wrist divided by the width of the wrist is greater than 0.7. When the thickness of the wrist is more than 0.7 of the width of the wrist, that's a positive square wrist sign. So if the wrist was completely square, a true square, then the thickness would be the same as the width and the ratio would be 1. So just by looking at your own wrist, you can tell that the thickness should be substantially less than the width. The ratio should be less than 1. So we need to obtain these measurements of the width and the thickness. How are we going to do that? Well, I recommend that you use the aesthesiometer instrument. And the aesthesiometer instrument is a two-point discrimination testing instrument. And you'll notice here, this is the baseline aesthesiometer. It has its 2 points for testing two-point discrimination right here. And although it's not intended for use for making measurements for the square wrist sign, it's a perfect instrument for that. And I really don't know how this could be done better any other way. So I recommend that you get this particular instrument both for your two-point discrimination testing and then also for the other uses that it offers you, such as testing for the square wrist sign. Some other uses that you get out of this instrument are found in the hand examination. I don't know how often you do hand examinations, but there's a couple of measurements of range of motion of the thumb. For example, thumb adduction and thumb opposition both have to be measured in millimeters, not in degrees such as the other joints are measured. These ones are measured in millimeters. And there's really no way to do it other than this instrument that I know of. This is the perfect instrument for doing some of these thumb measurements. So I recommend this as a versatile instrument to have in your doctor's bag. Okay, so we use this instrument to measure first the width of the wrist, and we simply slide our two-point discriminator to the appropriate width of the wrist. Okay, so there's my width, and that measures 61 millimeters of the width. And then the thickness, use this instrument, slide down and obtain the width of the wrist, which is right there, which is 34 millimeters. Okay, 61 width, 34 thickness. So to get the ratio, we take 34 divided by 61. What is that? That's a little bit over 50%. It's about 55%, right? Well, according to the ACOM guidelines, it should be less than 0.7. So this is a normal finding for me. Now, as the thickness of the wrist increases, that would be suggestive of contained and trapped edema and congestion, confirmatory for carpal tunnel syndrome. Okay, so doctors, these are some of the maneuvers that you'll find helpful in the diagnosis of carpal tunnel syndrome. All of these maneuvers, with the exception of the square wrist sign, which is really not a maneuver, it's simply just a measurement. All of these maneuvers are designed to reproduce symptoms of a pathologic median nerve. Now, as we said earlier, the report of symptoms is a purely subjective phenomenon. It's purely subjective on the part of your examinee. Hopefully these subjective reports of symptoms would be substantiated by other significant positive objective findings, including on physical exam the presence of a shake or flick sign, or perhaps some sort of reflex inhibition or withdrawal reflex from these noxious stimuli.